Well, I must say I've never given a talk at a venue like this. I feel like I'm on Idol or something. We're not used to that as surgeons. We're pretty conservative people. So I'm going to talk to you today about a very intriguing field of surgery. I'm the director of bariatric surgery at Mayo Clinic, and I'm going to go through a little bit of what I do normally every day, and then I'm going to share with you today what we're looking at for hopefully the future in treating patients that are morbidly obese. Just as a disclaimer, I have no conflicts, and I am a primary investigator of this device in a research study. So hopefully today we're going to become familiar with the current status of bariatric surgery in the United States. We're going to review vagal nerve function and its effects on weight gain and weight loss, and then discuss the new device that's currently in studies that help manipulate vagal nerve function. Well, when we talk about having surgery for weight loss, obviously that's a big deal. You know, there's a difference between just doing diet and exercise. The risk for that is minimal. But when we start to think about doing bariatric surgery, we talk about having to take a lot of risk up front, hopefully for, at the end, getting a lot of benefit from that. And so we don't offer this to everybody, and it should not be offered to everybody, not even patients that are of significant weight. They must be able to go through a program and show that they're able to comply and learn and are motivated and understand what they're doing. So our indications for surgery, which are most people's indications, the BMI should be greater than 40. BMI is an index of your weight divided by your height in meters squared. It's a little bit more accurate than those metropolitan life tables and those sorts of things. And so we can compare people to people relatively accurately. So BMI over 40 is considered morbidly obese. Greater than 35 with two comorbid conditions such as hypertension, diabetes, sleep apnea, those sorts of things would qualify them from a surgical standpoint. They must have gone through a non-surgical weight reduction program. Now, everybody's tried a diet, but there's no doubt that it's shown that patients are 3 times more successful in losing weight when a physician is involved in their care. And so they need to go through all that. Unfortunately, even with all of this help and all of the things that we know today, the success rate is relatively low. It should be less than 5%, unfortunately. These patients should not be abusing substances, of course, and I consider tobacco to be one of those substances. The last thing they need is more risk involved when they're going to undertake an operation. No psychoses or uncontrolled depression. They need to understand the risks and benefits of the surgery and the uncertainties. We don't know what's going to happen 50 years from now. We know maybe what's going to happen 25 years from now, but again, it's a longitudinal process. And they have to be able to comply, not just before, not just to get the operation, but they need to comply after, because that's just as important after the operation. Bariatric surgery has undergone an exponential explosion. And in 1991, there were about 20,000 procedures done in the United States. Now it's nearly 200,000 operations. The reason for that is that these operations were performed laparoscopically, which means we used small incisions, inflated the abdomen up with gas, put a camera inside, and so we did less damage getting to the organs that we needed to operate on. And that was really one of the main drawbacks of the operation, was that they got wound infections and hernias and those sorts of things. So there's a lot of people having the operation, hopefully a lot of people that are getting help. These are the 4 main areas that we look at for weight loss surgery: the gastric bypass, the sleeve gastrectomy, the duodenal switch, and the adjustable gastric banding. Now these are, I would say the most 2 common are the banding and the bypass, and I'm going to go through these real quickly. The laparoscopic adjustable gastric banding, as we heard earlier this morning, the stomach, when it expands, sends a sensation to the brain that you're done. And so what the band does is we put this around the upper part of the stomach, so there's a very small pouch, and then there's a tubing that's connected to a port under the skin. When we put fluid in that port, it squeezes the stomach and allows less food to pass through. The food accumulates in the pouch, and these patients feel fuller faster. We're able to adjust that out in the clinic, depending on if they're able to eat more or less. This is the gastric bypass. And what I talked about with the laparoscopic approach, small incisions on the abdomen. We're able to put in a camera, and we basically operate off the monitor, make the stomach very small. We divide the intestines and bring it up behind the stomach and attach it to the pouch here, and then we reattach down below. So as the food goes through, this is the roux limb. The food is not absorbed until it meets the digestive juices down farther. This length can be adjusted. This is a big deal. This is a lot of surgery. Luckily, we're able to do it with relatively few complications, but there are complications. It's not ideal. In fact, is no ideal operation for a bariatric patient. The ideal operation would have no real complications, and it would be effective 100% of the time. With the bypass, it's very effective. It's pretty reproducible. It carries its complications. The banding is not quite as effective, can be in some senses, but on average, not as effective, but it has less complications. So we're trying to find the perfect operation. This is the sleeve gastrectomy. It's sort of another restrictive operation where we restrict how much they feel that they can eat. We just basically divide off the outer half of the stomach. It doesn't allow the stomach to expand. You know, when you eat and you have a significant meal, let's say they call it the Thanksgiving effect, and you eat too much and you feel terrible. Well, what the stomach does to accommodate that is it actually relaxes and expands so you can accommodate more food. This happens on this part of the stomach, and once we're able to remove that, then they don't have that ability anymore. So hopefully over time, they'll continue to lose weight.